I'm going to discuss with the few brave that are here this morning instead of enjoying the beautiful sunny day and seeing the pyramids. I'm going to try to show you this new technique called STABILISE, which is very counterintuitive and requires a little bit of effort on our behalf in order to be understood and accepted. But before I do that, I would like to discuss briefly with you the reasons why aortas, after the event of acute dissection, over time, in many instances, in about half of the cases, have a tendency to aneurysmal dilatation. Well, the most intuitive reason that we could think of is that after dissection, the outer layers of the aorta become thin, they are more fragile, and so it could be only reasonable that this is the cause for further dilatation. However, we know from our clinical practice that there are situations in clinical practice where we are left with an aorta which is even thinner than the plane of natural dissection. And this situation is aortic endarterectomy. So when we perform endarterectomy in the aorta, for instance, for occlusive disease, we are left with a very, very thin layer of aortic wall. However, there is a lot of evidence in the literature, including this systematic review with almost 2,000 cases, that after endarterectomy, the aorta does not have a tendency to dilatation. And we also see this after surgical fenestration, after septectomy that can be done during open surgical procedure. So we know that in this situation, the aorta does not have a tendency to dilate, and therefore we can say that dilatation of the false lumen is not related to the thickness of the wall. So let's look at some other issues. For instance, if we go to this important pivotal study in New England Journal of Medicine of 2007, we can see that the authors found an increased rate of aneurysmal dilatation and mortality in patients in whom there was a partial thrombosis of the false lumen. Now this is very strange. Why should partial thrombosis do worse than no thrombosis at all? What's the reason for this? And the case seemed to be that the situation that leads to partial thrombosis is a situation in which we have a larger entry tear and a small one or more small re-entry tears, so that the patient is left with a maximum diastolic pressure that stays high during the cardiac cycle, especially during diastole. And so this situation, large entry, small re-entry, is linked to both partial thrombosis and dilatation of the aorta. And you can think of it in a way like a type 1 endoleak. So you have a large proximal place where the blood goes into the false lumen or the sac of the aneurysm with high pressure, and then there are small exits, and so the blood pressure stays high in this situation. So we have excluded the thinner wall of the aorta, and the reasons for dilatation are mainly the false lumen patency, partial thrombosis, and a persistent high pressure in the false lumen, mainly during diastole. So you can see the situation is that after the acute phase, maybe 30 to 50% of the patients will experience dilatation of the false lumen with reintervention and increased mortality. So we don't only need to save the day during the acute phase of dissection, we also want in these patients to prevent aneurysmal dilatation and its complications. So what can we do? What strategies can we employ to avoid this dilatation? Well, the most traditional strategies would be to try to induce a complete thrombosis of the false lumen. This can be done with the Knickerbocker or the candy plug technique if the dilatation is limited to the thoracic portion of the aorta. It can be performed with coils, with occlusions of reentry sites. It can be obtained with fenestrated EVAR, as in the beautiful case that we saw yesterday live from Paris, fenestration for treatment of dissection. But also there is another method which, yes, is less intuitive, but probably has even more efficacy, which is to try to induce the formation of an aorta with a single channel. And this can be obtained in several ways, both surgical and endovascular. One way would be septectomy. However, this would leave us with the lamella that is freely flapping inside the aorta like a flag in the wind. It may produce platelet adhesion. It may induce impingement of the lamella in the ostia of the branches, so it can be not optimal situation. And I believe that a very interesting and very favorable situation can be obtained with the so-called STABILISE technique. So the STABILISE concept is not my idea. It was introduced in 2012 by the Australian group of researchers led by Peter Mossop and Ian Nixon. And what they did was to perform initially the so-called petticoat technique, so placing a cover stent in the proximal portion of the aorta in order to close the proximal entry tear, and then add some bare stents in the more distal part of the aorta all the way down to the aortic bifurcation, and then using a balloon inside the stent graft, inside the bare stents, in order to intentionally rupture the lamella. So we want to balloon the aorta in every single portion from proximal to distal, so that the lamella is completely disrupted, is completely broken, and the layers, the inner layers of the lamella are allowed to go back to the outer layers of the aorta by means of the radial force of the stents. So this is the concept. This is a CT scan that shows you what kind of results can be obtained with this technique. You see that the aorta is completely remodeled, and I would like to underline the fact that this is not a lucky case. This is basically the situation that we obtain in all the patients in which we successfully perform the STABILISE technique. And this is a movie of the deployment. You can see that rapid pacing is performed, the initial cover stent, and then the bare stents are deployed, and then the balloon is not used in the proximal portion of the aorta. So in the proximal non-dissected landing zone, we don't touch it. Then we use this coda balloon where the cover stent is, and then we use this valvuloplasty balloon in the more distal portion where the bare stents are placed. And it should be pointed out that when we have important branches coming from the false lumen, in this particular case the left renal artery, we want to protect these branches. So after the placement of the bare stent, but before the ballooning, we are going to cannulate them with a sheath. We are going to protect them, and then if needed, we can place a bare stent in order to optimize the juxtaposition of the hole in the lamella with the target vessel. And these are surgical specimens that I would like to show you so that you can really understand what these holes in the lamella are. So when we have dissection, the layers of the aorta that come away from the wall of the aorta in the position of the branches, they always have these holes. And these holes can be you see, catheterized here So from the true lumen, we catheterize the hole in the lamella and then the target vessel. This was also done yesterday in the case from Paris for the right renal artery. And once again, this can also serve as re-entry tears distally, and they are always there. So this, once again, is a final result with this stabilized technique. Let me also point out that in this case, a carotid subclavian bypass with plugging was performed. And in our experience, we needed the branching of at least the left subclavian artery in 70% of the cases, because we are really strict on landing our stent graft in a non-dissected portion of the aorta. So let me just give you some tips for the stabilized technique. First of all, think about this technique. If you have an acute dissection that needs treatment, think that stabilized technique is available. And in order for it to make sense, you don't want the celiac aorta to be larger than 40 or maybe 42 millimeters. Why is this? Because if the aorta is already aneurysmatic, is already dilated at the celiac level, there is no chance for the lamella to go back to the outer portion of the aorta, so it does really not make sense anymore. It should be performed previously. So the oversizing proximally to the non-dissected aorta is around 10%. The initial coverage usually is 15 to 20 centimeters. We don't go all the way down to the celiac because this, I feel that unnecessarily occludes too many intercostal arteries, and this can have a negative impact on spinal cord perfusion. And then if we need two sets of bare stents, we don't want them to overlap in front of the splanchnic renal and visceral vessels. So we are going to plan the procedure so there is only one layer of bare stents in front of the splanchnic vessels. We never balloon the proximal landing zone, and this is the most important tip, the most important precaution that I strongly recommend you to follow. Use a latex balloon such as a coda or a trilobe only inside the cover stent graft, because inside the stent graft the maximum diameter that the balloon will reach is the diameter of the stent graft. So you are protected, you are safe. But never use the latex balloon in the bare stents. In the bare stents we want to use non-compliant balloon such as valvuloplasty balloons or venoplasty balloons, and their diameter should not exceed the whole diameter of the aorta. So this is the most important safety precaution. And after the procedure, all the important vessels should be checked for patency, especially the splanchnic, the renals. If there is some doubt, you can always chase them and stent them. If you have vessels that come from the false lumen, you want to protect them with a sheath before the ballooning. And many times re-entry will be in the iliacs, so you might want to consider also stenting the iliacs in order to completely remodel also the distal portion of the vessels. Now, of course, this all looks very nice, all looks very interesting, very promising. However, I must remind you that, sorry, I have a little issue with the slides. I must remind you that this ballooning of the bare stent is performed outside the IFUs of this product. So the IFUs of the dissection device from Cook specifically states that molding balloons should not be used. So we are using this outside the IFUs. And there is a lot of data that is already available in the literature, but they are all single center series, so we need more solid data. So I think it's very important that all the people who is using this technique use their data to obtain this solid evidence. So you have the opportunity to join the STABILISE registry in order to make this possible. So in conclusion, Chairman, ladies and gentlemen, aortic remodeling after acute diabetes dissection relates to large entry tear and small re-entries, partial false lumen thrombosis, persistent high diastolic pressure in the false lumen, and the creation of a single-channeled aorta is crucial to prevent false lumen aneurysmal degeneration. The STABILISE technique works, but we need to collect high-quality data in international registry. It is open to everybody. If you use this technique, please contact us at stabiliseregistry@gmail.com in order to gather this important data. Thank you very much.